What happened was I was developing a class for Education Day. I asked for an hour and a half for health system wide to give a class on this, and Dr. White said, "Oh, we need a class for Thursday," so here I am. So I had a couple of quotes. The first one is Albert Einstein, and it seems that from time to time we do this. We kept giving the same treatment, expecting a different outcome. The other three quotes are all Terry Gorski quotes, but I couldn't find them in literature, so I didn't cite them. But he said the most expected outcome from rehabilitation is relapse. Relapse is part of the disease, especially for relapse-prone individuals. If you don't understand relapse, you don't understand addiction. You really don't understand what's going on if you can't understand and work with the chronically relapsing patient. And relapse is a part of recovery for severely relapse-prone individuals. Some people come to treatment, they get it the first time, sober forever. Actually, we think almost 50%. Then that other 50% comes back, and they have, again, a 50-50 chance. I'm going to give you the data later. And then when they come back again, they still have a 50-50 chance. There's no notion or research or data to prove that the more treatments that a person has, the less chance they have. They all have the similar chance. They just need a different type of treatment. So a little bit about me, because what are you, a nurse, doing, giving a class to social workers and psychologists and all that kind of stuff. So a little bit about my military background. I served as a combat medic, 101st Airborne Division. I was in the California Army National Guard during the LA riots and Northridge earthquake. I served on a humanitarian make-nice mission to Panama after the invasion. I got called back to active duty after 30 years in 2004 to do case management for the guys coming back, Guard and Reserve people, ill and injured. A lot of course, combat stress and PTSD. I was in charge of the exam station, Los Alamitos, and had some other positions, commander of the 175th Medical Group Headquarters and Headquarters Detachment. Then I went to work. My first work in addictions was when I got out of school in 1975. I worked at VA Long Beach. And then I went to work at St. Joseph Hospital. I worked a long time, figured I'd retire there, but they downsized my job. So I had a lot of different positions there, and then I went to work at another private psychiatric hospital and also downsized itself. So I decided time to come to the VA for stability. I came to the VA, went in my office and figured, oh, this is great. I'll be there have this office 20 years, and I have the stability that I want. So I was working on a 40-bed single diagnosis alcohol treatment ward. I was supposed to create a day treatment program, and I did such a good job, the ward closed. Then I went to work on the mood disorders ward, and after that, the schizophrenia research ward, more about that later. Then I went to work in the community. We're shipping everything to the community in the MICM programs. Awards. I got some awards, too, along the way. These are just a few. The California Association of Alcohol and Drug Abuse Counselors gave me the Hall of Fame Award for 20 years of dedicated service to the organization. I had 2 VA best practices, one for MICM program development. I developed, in addition to the one I was working in, I developed the MICM program at Long Beach, Las Vegas, Loma Linda, and San Diego. And I got the Secretary's Big Advanced Nursing Practice Award in 2006, and I worked with the OIF outreach team and got a best practice for that in 2007. So here's some of the addiction medicine specialists.
I think we need to give you a raise.
I worked with along the way. So Dr. Joseph Ziska, many of you may not know this name if you haven't been around quite a time, but he was developer of the first military addiction treatment unit, and all the others followed. I also worked with Dr. Paul Oliger. He's Paul O. in the big book. He's now deceased. But this is the doctor that wrote Dr. Alcoholic and Addict in the big book, and he was medical director of the hospital I worked in for a time. I worked with Max Schneider, whose films were shown nationwide at one time. And Harvey, you still have some of Dr. Max's films in your office. They're a little out of date, but I work with him. Persh. Persh is famous for treating Betty Ford. Persh is an educator, psychologist. I work with him at CPC Long Beach. And Dr. Walter Lane developed the whole matrix model, Matrix Institute, and did all the research with that. And West LA, I work with some psychiatrists that actually, in addition to being West LA staff, were clinical professors at UCLA. Robert Gerner, known nationwide for research work in bipolar illness, and William Warshing actually wrote the book on Clozaril, and a lot of other medications were developed there. I worked for a time in the medication development unit, so we give medications, we didn't know what they were, because they're double-blinded, triple-blinded. They had like numbers, ZE423. So, but we did have education about the nature of the experiment that was required. And Andrew Shaner's done a lot of the dual diagnosis research, community resources with vouchers, and some of the behavioral reinforcement, and a big research grant on stimulant abusing cocaine addicts, and that had schizophrenia. Stephen Martyr, international expert on schizophrenia, traveled to China and all over to teach about schizophrenia. And I took some neat trainings. Father Martin, I'm going to come up with this in a minute. William Rader Institute, that was about the 80s when Rader got out of the military, the Navy. He started Rader Institute, started treating eating disorders. Sally Struthers, who's Sally Struthers? Trivia, All in the Family, right? Yeah. Meathead's wife. Sally Struthers was treated by that, and he did a little violation. He kind of developed a relationship with the patient. Our last training taught us that was wrong. But anyways, a famous guy, Ted Williams from the U.S. Navy, I took classes from, and although he's now deceased, I was fortunate to take classes from Dr. Albert Ellis, including substance abuse, specific substance abuse training. Aaron Beck, I took trainings from. It's kind of boring. Oh, I better not be boring. I've taken most of my training from Karen Skorsky. And oh, look, a screenshot from Chalk Talk on Counseling. And here I am in 1976. So yeah, that's. I actually looked all over. I come and raided Harvey's office looking for all this. I found it in the drawer. So, oh, great, I did that because I'd seen it once and it was in it. So now I burned the copy. Oh, teaching assignments. I taught at Alcoholism Research Institute, mostly continuing education. Then I taught in Counselor Training Institute, and I taught the Human Service Department at Saddleback College. UCLA, I did management work where they would send the management students in the BSN program, and I taught psychiatric nursing at Mount St. Mary's College and Western University. Okay, so why relapse prevention? What was the old way? Here was the old way. You got to confront it, right? Alcoholics and drug addicts have big egos, and they need to be diminished so that then we can build them up. How arrogant of us. So here's the outcome. This is published in Counselor magazine in the early 80s. And so they assessed outcome, that's sobriety and counseling styles. So high confrontation had the worst outcome. You want your patients to leave, not listen to you, just give them high confrontation. And as a tribute to their mental health, they'll go away. Medium was kind of in between. Low confrontation style has the best outcome. Now, counselor characteristics. What is the characteristics of a good counselor? A female who is senior in age to the client. So, all us men are less effective. This is from research. I'm not making this up. And now, what about educational preparation? Dr. White is shaking your head. No, that's correct. Peer counselors, which are a lot cheaper, are as effective as PhDs by research.
Wow.
Yeah, so if you want the research, I'll be glad to send it to you. So, methods. Most methods are equally effective. Same with PTSD. You read PTSD research, Dr. McConaughey knows that I'm a compulsive reader of PTSD and substance abuse outcome research, but mostly it says, it all works better than nothing. Okay, so, Project Match, biggest, most expensive study done in substance abuse. So, while Project Match was going on, Project Match compared CBT, I'm a CBT fan, MET, I'm also an MET fan, and traditional addiction treatment called 12-step facilitation. And actually, we do all three of these here. I'm a CBT guy, so, I'm rooting secretly, hoping, my side wins. Everybody wants their team to win. But results came out, and it's kind of equal. The researchers found that 12-step facilitation was slightly but not significantly better, and they attributed that to most people were more familiar with that style when they did that. So, what does relapse look like? We have the idea, we tell the patients that a disease is a disease, it is a disease, and for a while I thought we were just making that up. But actually it does look like, and newest research about dopamine and various forms of the addictions and brain imaging are finding out that it's all similar brain centers and brain chemistries. And so the relapse curve, this is 100 people try to quit over time, for alcohol, heroin, and smoking are about this. I mean, the curves are very similar. So it kind of looks the same. Now, it's those bad alcoholics and drug addicts that are always relapsing, right? That's the notion of many healthcare professionals, that alcoholics and drug addicts are subject to relapse. Of course, the diabetics and cardiac, they never relapse, right? Wrong. So, this is JAMA, Journal of American Medical Association. So, over time, the relapse rates are very similar for drug dependence, alcoholism included, to other chronic lifestyle problems. So this is good to teach the patients also. So mostly I've been using the Gorski synapse model for relapse prevention, and that started in 1982, so it's not anything new. This was the book Counseling for Relapse Prevention. I'm going to go through some of this with you. Now, there's also another school of thought in relapse prevention, Marlat's school. Gorski is more of an Ellisonian, RET, REBT type. And Marlat is more CBT, cognitive behaviorist, a little more strict Beckian type. So I really do think people have feelings, and CBT kind of leaves out the emotional state of people. So I'm more leaning toward the Ellisonian model myself. Anyway, now there's only one authority, because unfortunately Alan Marlat's passed away within the last few months. He did another of the early books on the relapse prevention. And research is kind of a researcher, clinician in Washington. He developed this. This is a most recent thing, probably the last major publication by Marlat on mindfulness-based relapse prevention. Now, I've read this, and here's the way this goes. This is 8 single sessions, and the results show that the mindfulness is much superior to the general type of treatment. Now, what is mindfulness? For the Marlat approach, for those 8 sessions, almost half of every class or group, whatever you wish to call it, was spent in meditation. The clinician teaching, demonstrating, and doing meditation with the clients. Now, we do that differently here. We do much more than 8 hours training, and George is here. George is teaching a lot of mindfulness. So I think we kind of have some of these elements already. And then last thing, we don't use this here, harm reduction, but Marlat also made a big contribution to harm reduction in the community and other settings. Harm reduction is a much better technique to use. For instance, I was working in the community, I'm working in Mickham, and I go out and find my patient drunk, I can't discharge him because they're my patient for life. Yeah. So here it's easy, we get to brush our hands of the little problems by discharging them, right? But the patient still has the problem. We kind of clean ourselves up. Okay, so harm reduction is good in other settings. We're more, devoted to these other methods. So, what's the theory of relapse prevention? You taking this?
Thank you.
So, theory of relapse prevention, and I showed you the graph. It's just like any other chronic lifestyle illness. Now, would we say, we like to have it both ways about is addiction a disease? Sometimes it is when we decide it is, and sometimes it ain't when we decide it ain't. So, if a patient had been in our hospital and was discharging and going out in a wheelchair and had another cardiac event, would we say, no, we've actually just treated you and you should go out and meet with fellow cardiac victims for 30 days and get this little card signed, and then if you come back and you show us that you're serious about recovery, we'll take you to the ICU again, hook you up all the life-saving equipment, save your life. Or if they brought the diabetic patient in insulin coma into emergency room, would we say, no, I'm sorry, you're not motivated? No, we'd save their life. Okay, so relapse prevention is built on this kind of theory. So patients are going to relapse. It's going to happen. Now, why do we react to that? We feel kind of powerless, let down. They couldn't recover. They didn't follow my wonderful advice, So you only can take credit for the successes if you're willing to take responsibility for the failures. So it's unrealistic to expect zero relapse rate. Now, the old policy, Dr. White is here and knows the old policy. Hey, we were immune for a year, right? Don't even ask. And then it went to 6 months, and somebody in Washington has wised up and must understand relapse because they've changed all our ways. And actually, it's good for the census too, right? So there's a lot of good things about it. So what is realistic? To reduce the rates of relapse, to manage relapse episodes more effectively. Now there's some criteria. And this, actually, Dr. White, you and I are the only group. John, did you go to the Gorski workshop? Mm-hmm. Yeah. There's only 3 of us that even went. Oh, George went. Did you went? You were here last? Yeah. Oh, okay. So several people were. I got this information all from the Gorski workshop. I'm not making this stuff up. So if we are effective, our frequency should be occurring less, relapses should be occurring less often, and they should be getting shorter. Now, take our admission policy and the notion of having relapses getting shorter. So if we refuse a person that wants treatment, they go out and get sicker and go to 4A instead of we could have taken them in. If we save the taxpayers money, which is one of our missions, we cost them money. Severity, having fewer consequences. I just talked about that. Why should people get sicker? Want to be well. We're health workers. We're health oriented. And this is more for administration. The cost to manage, because there are calculated costs. The cost of a day of treatment here is a calculated amount. The cost of a day of treatment on 4A is a calculated amount. The cost of an ER visit is a calculated amount. Okay, so a lot of relapse prevention in the book is based on the 37 relapse warning signs. And while he was here, Mr. Gorski said he developed this because when he was first out of school and knew everything and was telling the more seasoned clinicians how they ought to be running the clinic, they gave him all the worst patients to shut him up. So what he did was started to do analysis of the themes occurring in people that relapse. So kind of a humanistic experiment to develop themes and patterns and then teach these patterns to other patients so they could prevent relapse. And actually, this research does show that 37 relapse warning signs is a is a valid predictor of relapse if you use it. This is some research out of Marlat's work, and this is a meta-analysis of all the relapse prevention in the literature, showing the control and relapse prevention much better than the control. Briefly, and everybody has this in handouts, and I have it all on one page if you wish it, and I'll send it out. The first part of the relapse is started with return of denial phase, and we see this. People are here a while, they come in, they're sick, they're willing to do anything to get well, and then after a while their defenses build again. Now, the first thing that happens is they question, am I able to stay sober? Now, this is a point for an intervention if you determine this, because a lot of these people, particularly the relapse-prone, believe that it's kind of their destiny, their doom, their life karma to live this repeated cycle of in and out of hospitals. So we need to do mind change, to do cognitive restructuring for the people that actually believe it. So I do that kind of work when I find this coming up in the groups. So that's concern of well-being. Denial of concern. So don't worry about it. Don't think about it is the second thing that happens. Then the third thing, and when you hear the patient say this, it's not a good thing. When the patients come and say, hey, look, I understand it. Alcohol's the problem. I'm never going to drink again. That's nothing to reinforce. When I hear that, I tell them, because I teach this, I say that's a number 3. Because they're already on their way to the next relapse. Because when the client says, I'll never drink again, that means he doesn't really have to make the required lifestyle changes. And you see the patients come back in again because they've just decided to quit, and they're going to keep going to the bar with their buddies and hanging out at the dope man's house. They're not making the lifestyle change. When they know that they're cured, they came away for the Prescott cure, then they don't have to worry about that. Now the next one, worrying about self and others. Yeah, sometimes we encourage that here, but often it fails. And that's what Alcoholics Anonymous call the 2-step. First and the 12th. I'm powerless, let me fix you. Becoming defensive, we see this often, and people identify and go, they're beginning in relapse mode. But if you sit down and go through the 37 relapse warning signs and just check them off for them, it's a tremendous intervention. They will get it. Compulsive behavior, impulsive behavior, we see this around here all the time. And loneliness and isolation. And then the crisis builds, they get tunnel vision, they begin to get depressed. Does this depression need to be treated? Medications? Likely not. Because it's part of the relapse cycle. Idle daydreaming and wishing to be happy. And then feelings that nothing gets solved. The relapse warning signs build. This one is the number. Send this back to Dr. Dusty.
I got one.
Oh, okay. This is related to number 1. Concerns that I'll never be able to get well. And so now that's building. They're daydreaming. And we just heard somebody say this yesterday in the treatment plan meeting. I could have been an athlete and stuff. I could have been it. But it is what it is. Feelings that nothing can be solved. I'm always going to be a chronic relapser, and immature wish to be happy. We see a lot of immaturity here, maturity level for these people. Mostly we think is about the age they start drinking or drug using. So we see a lot of adolescent behavior. Periods of confusion, easily irritated. So these folks that are easily irritated, the intervention is to say, let's see, it looks like you're working up to a relapse, and here's the 37 relapse warning signs. Where are you on this? Oh, looks like you're in trouble. So that can, refocus them. Depression builds. There's depression earlier, so they're beginning to get more depressed, irregular sleeping habits, loss of control. Now, our oversimplification of the past was people relapsed because they quit going to AA meetings. That's been an oversimplification of the past. So withdrawal is, they're 2/3 of the way down when they even start to reduce their number of AA meetings. Developing an I don't care attitude, we get this, they get in staff members' faces. Dissatisfaction, feeling that life isn't worth living. They begin to feel sorry for themselves. We see a lot of that. They begin to seek thoughts of social drinking. Now, are they going to tell you this in group? Only if you're fishing for it. Conscious lying, they know that they're lying to themselves and to you. Developing unreasonable resentment. Sometimes it's against staff, they have a conflict, My treatment coordinator doesn't understand me. Those nurses downstairs aren't taking good care of me. Dom Medical won't get me in to see me when I want. I can't just walk right in and get treatment. Well, I'm in copper team. I can't walk right in copper team and get seen when I want either. So now it's building. Overwhelming, lonely, frustration, anger, and tension. So sometimes the folks just leave, right? This is about where they just pull the plug and leave. Some stay. The acute episode starts, and here are the symptoms. So this is the complete degeneration of everything. They're going to go again to the bottom. Our concept is to raise the bottom and try to prevent these cycles of in and out. So I included this for the handout, how to use the relapse warning signs, which is to first have the client identify what of the relapse warning signs apply to them, and then build a list and put it up, review it morning and night, and tell family and friends and sponsors what are their relapse warning signs, so that they can get some external reminders when they get kind of into the tunnel vision thinking. I do it a little different in the relapse prevention program that'll come up, because in the relapse prevention program they actually write out a relapse prevention plan based on their potential triggers or high-risk situations. Okay, next thing, how to do a relapse assessment. So, often people say, he's drinking, he's relapsing because of his family problem, he's relapsing because of his childhood problem, he's relapsing because of his PTSD, he's relapsing because of this or that. But often it's done without an assessment. So here's how you do the assessment to tell what's really driving the relapse. So, start with a period of good sobriety. For many of my guys, it's the last time they're in the dom. So, then you go through the 37 relapse warning signs and say, what happened here? How did this come? Check off all these things that happened. And then the first use is very significant. And almost all these guys will recall going into the market and buying the first bottle that started the relapse, or the trip to the dope man's house to get the dope. And they will remember what they were thinking, their self-talk, and any dialogue they were having with themselves about it, because it's this that we want to reverse. Determine the relapse dynamics, so you have to know a little bit about it, and then just educate the client. Say, well, if you see this happening again, we're going to go into the self-talk in a minute here. That comes later. So anyway, this is how to do it. More comments on this later. Developmental model of recovery. So the Synapse model uses progressive stage of recovery, developed mostly by observing people in long-term sobriety in Alcoholics Anonymous. What they did successfully and what they didn't do. If they did something out of order, what tripped them up. So the developmental theory said developmental tasks should be completed in order, and recovery task incompletion, just like in grief, we say if you're grief and you get stuck in a stage, you need help to get out of that grief stage into the next grief stage. So similar for developmental model of recovery, and completing the recovery task out of order may cause relapse. So we'll get into that in a minute. So the model looks like this first, and I've contrasted this with Prochaska and DiClement, a good model for people stopping smoking. But for instance, smoking is a unitary event. People decide to quit, and then it seems to be over unless they relapse. So quitting smoking doesn't seem to have these stages. Don't know why. The addictive index of nicotine is as high as it is for heroin, but the quitting process seems different for some reason. So there's really not a lot of good evidence that this is a good model for substance abuse. I have the references for that if you want. Transition stage, I'm thinking about it now. Maybe I should go to the hospital or go back to the hospital. So this is the Prochaska and DiClement contemplation. I'm going through this quickly because we don't see these folks in this stage. If you do community interventions, you see people still drinking. You can't work with them. And then you get to do interventions with people. But by the time they come here, they're kind of in between stabilization and early recovery. So it becomes important to say what is task completion in each stage, because our job is to get them through each stage to different stage to different stage. So during this stage, patients recover from acute and post-acute withdrawal. So when they come in, most have, not all, have recovered from acute withdrawal, but we see a lot of post-acute withdrawal, so that's coming up. So this is preparation, early recovery. So phase one, first couple of weeks, probably patients are still in the stabilization phase. Early recovery. Now, I added in the theme that Jerry talks about. So the important thing in early recovery is self and sobriety. What's going on at home, the business, the car, the dog, that kind of has to be secondary. People can get so trapped on everything, everything that's happening in their life that they can't concentrate here. In the old days, and actually up till recently, some people have come from other treatment centers. You make no phone calls for 30 days. You don't go anywhere for 30 days. You're complete isolation. I think that's a little overkill. So during this stage, patients learn to replace addictive-centered thoughts, feelings, and behaviors. So you can see the RET in here. Thoughts, feelings, behaviors. With sobriety-centered thoughts, feelings, behavior. That's kind of the theme. Middle recovery, the theme is self and society. So our guys here in phase two come homeless off the street and he got nothing. So, think Maslow, what are their needs? During this stage, they repair the lifestyle damage for our guys. Homelessness, joblessness, families gone, and develop a healthy and balanced lifestyle. We'll come back to balance later. And then late recovery is a time to resolve family of origin issues. Actually, developmental model was written before PTSD became a diagnosis, and Terry was supposed to write an article, co-author an article with me to update it to include PTSD and late stage recovery. The notion of this is people need to become solidly sober before they start addressing these issues, because they destabilize, they get worse before they get better when they address their PTSD and early life issues.
John?
Sir?
I get a lot of patients when I'm doing the H&P who will be, veterans with a history of PTSD, and they will assert to me in the H&P that, oh, well, my PTSD is totally uncontrolled, and I'm self-medicating with alcohol or the marijuana or whatever drugs, and I'm here for PTSD. I don't have a substance problem. I want treatment for my PTSD. But what you're saying is that in this model, the substance abuse should be treated first. So how do we approach a patient that has that mindset?
What I'd ask you is just to say, we're going to get to that in your treatment. I want you to meet with your treatment coordinator, have your treatment team meeting. We'll let us build a little more data. That's what I would suggest.
Are there circumstances where you would address?
Yeah, I'm going to get to that.
Okay.
Actually, I'll talk about it now. Okay, so here's some, remember, I taught about how to do a relapse assessment. So you need to ask about what's building up to the relapse. They're just kind of laying out their plate. And in my experience, people come with all these problems. I need help for this and this and this and this and this and this and this. They got a dozen problems. So what I usually do with them is say, first, because they're just wanting to dump all their stuff, I say, gee, would you make a list of all your problems, please? Okay, good, they bring the list. I say, okay, now prioritize them. 1 must be taken care of right away, 2 can wait, and 3 can wait a long time. Then I get all the ones. And then I say, well, which one do you want to work on? Kind of narrow that down. Now, I have seen people that do need concurrent PTSD treatment. Here's one example. Before I came to work in the VA, I was working probably the only veteran working, and now there are a couple others in other departments. I was working in a detox rehab center, 10 beds detox, 26 beds rehab, and we had a Korean War veteran amputee, chronic alcoholic. And when he came in and started to detox, he was back on the landing zone in Korea where his leg was blown off. He couldn't get past it. So he needed concurrent treatment. At that time we didn't really even have such a notion. I don't think PTSD was really a diagnosis then, but I knew as a veteran and former combat medic what was going on with the guy. So don't think at that time we did a lot for him. Second, guy that I served with, Marine, Vietnam War. First day in combat, got his M14, back that far, and a teenage girl rigged with explosives charged his platoon. And he pulled the trigger. Now, I'm told, and I didn't ever see this happen, I'm glad, the guys talk about the pink mist, because when the bomb goes off, it disintegrates the body, and it just becomes like a pink, kind of a hologram thing. And every night when he goes to sleep, to lay down, guess what he sees? The pink mist. And guess what he does every night? This is an insulin-dependent diabetic. He's drinking a fifth a day. He's also an officer in the Army National Guard. We did an intervention on him. Didn't work. Threatened to take his commission away. Didn't work. Still drinking. Close to death. Drinking away the pink mist. So that's another example. You know, that's somebody, but we have to do a little assessment to find out. Third example is here. One of them now deceased. And another one, I'm not sure what happened. But these are guys who are saying, I'm drinking because I'm constantly replaying, reliving. The video is playing in my head all the time. I can't shut it off. So those are people that need lots of medicines, concurrent. You know, they need a kind of a team approach. So, no, it's not simple.
Yeah. So practically speaking, when I encounter that situation with the H&P, I should hold off on making anyone from the PCT team aware at that point. Who is it that will make this determination later on? Is it you as a
Well, I'm not.
coordinator? Is it
I would defer to Dr. McConaughey and Dr. White, but generally that would be my recommendation. Just say this will be, you're going to have a complete psychiatric assessment, or psychosocial, whatever you want
I
to
think
call
we
it.
need to clarify that.
Yeah, so that would be my suggestion. Let the treatment team sequence this. And I have some patients I've referred right away. They need to get down there now, immediately. Others, let's wait. So I'm generally opposed to cookie cutter approaches. Yeah, we always do this or never do this. Yes?
If I'm correct, I don't think the PCT team even requires sobriety before they start treatment.
Yeah, don't.
Outpatient.
You know, I only got 8 more minutes. Let me go on. Okay, so maintenance. This is the wise old guys in the AA, been sober 20 years, and ask the newcomers, tell me what it says on the first page of the big book. What does it say on the first page of the big book? Nothing. It's blank. Anyway. All righty. Now, the other part of this is teaching the patients about the addicted self versus the sober self. Actually, we don't see a lot except in the building up to drink part. But when these guys are drinking and using drugs, this is what they've done to their family, their community, their employers. mean, angry, nasty, the drugs are in control, and don't care about anything except for getting more booze and dope. Because you notice these guys will lose everything before they quit. The house will go, the job will go, they'll be homeless, they're still using the primary love object. So they have this I-thou relationship with the love object. Sober self, many of our people in good recovery are nice, easy to get along with. So the model of this is to teach the patients that there's really kind of two of you in your addictive voice and your sober self, and they're kind of fighting. And I like the yin and yang model because it says even when you're sober, that little voice, the little, this little thing's hanging around, it's waiting to get you, so you have to be vigilant. I don't know if y'all remember when I started, people told me, Guy, you can't do a relapse prevention program because you'll talk about relapse and cause relapse. I knew that was bogus, but I didn't argue with folks. I wrote Jerry Gorski, and he wrote back and said, not thinking about relapse causes it. So teaching people about relapse doesn't cause it any more than asking a patient if they're suicidal cause them to kill themselves. Let's see. So goal is to put the sober self back in charge. By the way, when you engage this person, because they'll be here, you're holding that person in the addicted self. So the idea is we want to engage the sober self and kind of, I try to ignore this as much as possible, unless it's creating a major problem. Okay, post-acute withdrawal. I sent out things, and a lot of what goes along here with our patients is in post-acute withdrawal. So first they need education. I'm doing like once a cycle education about post-acute withdrawal, and then teach them how this is related to their drug abuse. Other general recommendations is avoid stimulants. How are we doing on that? Coffee everywhere. Coffee everywhere. Don't even have it. Decaf is what you get. But they get 3 times a day, they get coffee downstairs, they make coffee in their community, need sleeping pills. And that's why other places don't do it. Use of sedatives, because they're pharmacologically optimistic people who are fixing everything with a chemical. I'm anxious, give me a pill. We should be teaching stress reduction, relaxation, mindfulness for all this, and encourage recovery-oriented. Every patient needs education in coping with cravings, because the cravings will come. I ask patients every group, what is your craving level, 1 to 10? And so if they're telling me they have a high craving level, I stop everything and work on that, because if it builds, guess what? They're out the door drinking. Okay, so this is a little bit, we're coming to the home stretch. This is a little bit about the relapse prevention program, and remember I did this for the folks on the outside. Criteria to get in for more previous treatments or alcohol and drug use and treatment. And you all know it's more restrictive. They have to have a safety plan to go out and use a Gorski relapse prevention therapy. Most of the stuff is taken out of this book, which is a workbook manual, but I've just taken stuff out because I know the VA isn't buying every patient a $30 manual. So I've taken some things out. Mr. Gorski knows I'm doing it. So in the relapse prevention program, they get 5 assignments: relapse history, alcohol and drug history, this 37 relapse warning exercise. From that, they develop a relapse prevention plan. They also make a plan, what should I do in case I have a lapse, which is, less than 24-hour drug use, the chronic deteriorative symptoms are not restarted, and we hope to put people back to recovery. So how'd you do, Guy? So first 2 months, remember, the history is interesting. It was April Fool's Day. There was I'd been talking to Dr. White about starting a relapse prevention program. We had a patient here in treatment that was a hospital employee who relapsed. And we were a little codependent. We wanted to save his job. Didn't work anyway. So I said, Dr. White, let's just start today, okay? She said, okay. So that was April 1st of last year. First couple of months, terrible results. Took a little burn in for them to get used to this. And then, tremendous results. By the way, Dr. McConaughey, I've adjusted all these to what I think is the correct data. here through this, I'm certain of it. So it looks like during these months, June to October, I'm doing great. Almost no people are leaving the DOM that are in the relapse prevention program. And then what happened? Spice. The spice epidemic hit. We had a lot of people. It was a crazy time in the DOM, you recall. Second chance program. So in the beginning, we said we got this relapse prevention program. People are drinking. We'll give you the opportunity. If you want to go in the relapse prevention program, you can. We only took in 10 in the first year. 8 of them were irregularly discharged. They drank again. 2 were successful. So then the criteria was changed to say, and this was actually based on Ramiro's experience at another DOM, that you have to ask for help, and that seems better. And sending people out to reapply actually does seem therapeutic in a way. 12-step resistance. So when the patient says, I don't want to go the 12 steps, is that a showstopper? Yeah. When the only tool you have is a hammer, everything looks like a nail. Now we have smart recovery. There aren't the different, and in addition to that, there's the Heights has Celebrate Recovery. We have smart recovery, so there are many different options if they say they don't like the 12 steps. Yes?
Are these other models evidence-based? Do they have the data to back up their efficacy? Because I know 12-step was the only one for a while.
Yeah, 12-step effectiveness is 25%. I'll send you the data. It's 25% effective. Would you send a person to surgery that had a 75% chance of failure?
If they were terminal. If they were going to die.
Okay, right. Right, and they are. Anyway, so yeah, we think similar. The methods are different. The outcome measurements are different. They're not using the AA methodology. So smart recovery is attractive because there's no steps, no higher power, no sponsor system, no lifetime commitment, and it uses cognitive, behavioral, and rational emotive methods. Okay, so, anything else? I'm here. You know how to get me. That's all I have, and it's now 0900.